Welcome everyone to the third year B Pharmacy semester 6 pharmacology 3 class, and the topic which we are going to study it is antiviral agents or antiviral drugs. So in last lecture we have studied about a few things about the viruses, how they infect us, how they enter our body, how they create or how they circumvent our host cell mechanisms, immune mechanisms, and how they take an alternative route to enter our bodies. Okay. So that all we have studied. Now we are going to study the antiviral drugs, and specifically today we will be talking about antiviral drugs which are acting against non-retroviruses. So first of all, the possible targets of action of antiviral drugs. Understand the content which I have presented over here in the slides. I have taken it from the Goodman and Gilman, and the second book which I have referred is the Lipincot's Pharmacology. That will be the source material for the today's presentation. Okay, so let's get back to the slide. That is the possible targets of action of antiviral drug. So why we have included this particular point the in this particular chapter is that first of all we have to understand which are the different processes that is how the viruses infect the human beings, and depending on the step of the viral infection process, the drugs which we employ. Okay, so the stage of replication, the first stage is the cell entry, in which there is attachment and the penetration. Okay, so the classes of inhibitors or classes of drugs that act on this particular stage are the soluble receptor decoys. Decoys means these are the dummies that are created. Okay, so these are nothing but receptor dummies. Okay, then we have the anti-receptor antibodies. So these antibodies, they bind to the receptor against that particular receptor, and they don't let the viruses to bind to that particular. Then we have fusion protein inhibitor. Okay, then the second stage is the uncoating, so in which the result is the release of viral gene, and the class of drugs that act on this particular stage are the ion channel blockers, then the capsid stabilizers. Then next, third stage of replication is transcription of the viral genome. So in this, the transcription of viral mRNA and the replication of viral genome that happens. So the drugs that act on this particular stage include the inhibitors of viral DNA polymerase, then RNA polymerase inhibitors, then reverse transcriptase inhibitors, then helicase inhibitor, then primase inhibitor, or the integrase inhibitor. Okay. So you will be studying about the various drugs in this particular chapter, so you will be able to correlate all of this when you will study those, the mechanism of those drugs. Then translation of the viral protein. So again there are two types of proteins that get formed, that is the regulatory proteins, and these protein get formed early in the process, and then we have second category of proteins, that is structural protein, and they get formed late in the process. So the classes of selective inhibitors that act on translation of viral protein include interferons, then antisense oligonucleotides, then ribozymes, then inhibitors of regulatory protein. Then we have next stage of replication, that is post translational modification, and in which the processes that happen, that is proteolytic cleavage, then myristylation and glycosylation. So the drugs that affect this particular step or stage is the protease inhibitor. Then we have assembly of virion components, and the drugs that affect on this, they include the interferon, then assembly protein inhibitors, and the final stage of replication, the release, which includes the budding or the cell lysis. So we have already seen about this. There are two processes by which the viruses, they can get released from the host cell, that is either by budding or by the cell lysis. And the drugs that affect this release stage, they include the neuraminidase inhibitor, then antiviral antibodies, and the cytotoxic lymphocytes. Okay. Then this classification is as per the Lippincott pharmacology. So it classifies the non-retroviral drugs as for respiratory virus infection, for hepatic viral infection, specifically we talk about hepatitis B, then hepatic viral infection, hepatitis C, then for herpes virus and cytomegalovirus we have certain drugs. So for respiratory infection, we have amantadine, oseltamivir, ribavirin, rimantadine, and zanamivir. For hepatitis B, we have adefovir, then entecavir, then lamivudine, like peg interferon alpha 2A, then we have tenofovir, alafenamide, that is TAP, then tenofovir, disoproxil fumarate. For hepatitis C, we have taclatasvir, then elbasvir, grazoprevir, then glecaprevir, fibrintasivir, then ledipasvir, then sofosbuvir, then paritaprevir, ritonavir, ombitasvir. So understand this oblique sign wherever it is mentioned. These drugs are used in combination. Okay, so this paritaprevir, ritonavir, then ombitasvir plus dasabuvir, that is the combination. Then we have ribavirin, then we have cimeprevir, then sofosbuvir, then velpatasvir, then sofosbuvir, velpatasvir, or voxilaprevir. Then for herpes virus and cytomegalovirus infection, we have acyclovir, the very important drug. Then valacyclovir, then valganciclovir, then ganciclovir, then pencyclovir, then cidofovir, then funcyclovir, then foscarnet, then trifluridine. So actually the uh, pronunciation of this is ganciclovir, not ganciclovir. Sorry for that. It is ganciclovir. Then we have a slightly different replicative cycle of the RNA virus. Why we are talking about RNA virus and DNA virus? Because the drugs which we are going to study, they act on this particular replicative cycle. That's why it needs to understand these replicative cycles. So this RNA virus, it binds to the cell surface hemagglutinin. So by means of endocytosis, it is taken inside. So this is the endosome. So the H plus ion, they influx happens, and there is a M2 protein into the M2 protein with which it attaches to. Then there is him agglutinin fusion takes place. So the M2 uncoating happens, and this M2 uncoating, it is by amantadine and rimantadine. So once this M2 gets uncoating is done, the vRNA is released, and in presence of this RNA-P, it gets converted to the cRNA, and again in presence of RNA-P, gets converted to the vRNA. So copies of vRNA are getting formed. Okay, so in between step it's cRNA. So in another way, another route, in presence of RNA-P, it forms the mRNA, and this mRNA formation is responsible for the protein synthesis. The proteins which get synthesized, they are the structural proteins and the non-structural proteins. So this vRNA and structural and non-structural proteins, they combine to form the viral particles. So this intracellular transport and assembly happens, and this viruses which get formed, they get released, and the release of these viruses by means of budding is inhibited by zanamivir, then oseltamivir and peramivir. Okay. So the first drug that is used in respiratory tract infection, that is neuraminidase inhibitors. So these inhibitors, the examples are oseltamivir and zanamivir, and they are effective against both type A and type B influenza virus. They do not interfere with the immune response to the influenza vaccine. Okay. So they are administered prior to exposure. The neuraminidase inhibitors, they prevent infection, and when administered within 24 to 48 hours after the onset of its symptoms, they modestly decrease the intensity and duration of symptoms. So if administered prophylactically, they won't let infection to happen, but if administered after onset of the symptoms, they modestly decrease the intensity and duration of symptoms. So next drug, that is adamantane antivirals, and in which we have two examples, that is amantadine and rimantadine. Okay. So therapeutic spectrum of adamantane derivatives, that is amantadine and rimantadine, it is limited to the influenza A infections only. So it is, in one way you can say that it is a narrow spectrum antiviral, as it is affecting or can be used in influenza A infections only. Okay. So next drug is the ribavirin. So this ribavirin, it is a synthetic guanosine analog and is effective against broad spectrum of RNA and DNA viruses. So ribavirin is also effective in chronic hepatitis C infections when used in combination with other direct acting antivirals. So these direct acting antivirals, we can write their abbreviation as DAA. Okay. So next is treatment of hepatic viral infection. So we have a variety of hepatitis causing viruses, that is A, B, and E. But out of these five viruses, the most common viral infection that are seen, that is the hepatitis B, which is a DNA virus, and hepatitis C, which is an RNA virus. Okay, so they are the most common causes of chronic hepatitis, then cirrhosis and hepatocellular carcinoma, and they are the only hepatic viral infections for which therapy is currently available. So the mechanism of action is incompletely understood, but it is assumed or it is hypothesized as that it involves the induction of the host cell enzymes through the activation of JAK-STAT tyrosine protein kinase receptor, and thus causing the inhibition of viral RNA translation, and it ultimately leads to the degradation of viral mRNA and the tRNA. Okay. So this is the one thought process or one mechanism of action which is of the this interferon. So interferon alpha 2A, it is approved for the treatment of chronic HBV infection, and also indicated for the treatment of the HCV in combination with other agents although its use is uncommon due to availability of more effective agents. So the adverse effect of it include the flu-like symptoms such as fever, chills, myalgia, arthalgia, and the GI disturbance. So the fatigue and mental depression, they are common. The principal dose limiting toxicities, they are bone marrow suppression, then severe fatigue and the weight loss, neurotoxicity which is characterized by the somnolence, then behavioral disturbances, then autoimmune disorders such as thyroiditis, and rarely it causes cardiovascular problems such as heart failure. Next drug is adafovir. So this adafovir, it is also a nucleotide analog and it is phosphorylated by the cellular kinases to the adafovir diphosphate, which is then incorporated into the viral DNA. So once it is incorporated into the viral DNA, it causes termination of chain elongation and thus it prevents replication of the HBV. So see, the nucleotide analogs, they are preventing the replication of the viruses. Okay, so this adafovir, it is administered once daily and renally excreted via the glomerular filtration and tubular secretion. Let me first tell you about this in detail. This adafovir or nucleotide analog like drugs, they are just the look like drugs. Okay, they are look like, they are not the nucleotides, they are look like. So when these drugs are given, they first need to be get converted or they need to get phosphorylated first. So once they get phosphorylated, they get into the form which is actually used in the synthesis of the DNA, the genetic material. Okay, so as they get into the form of the product that is being used for the DNA synthesis, instead of taking the natural substance, natural nucleotide, the virus, they cannot distinguish between whether it is the natural nucleotide or it is the synthetic one. So they end up taking the synthetic nucleotide like the ones which we have seen over here, and as and when they take it, they cannot proceed with the actual replication process because this is not a natural thing. So the process which they are carrying out, it falters, and as it falters, they cannot replicate, and the replication stops. And that is how these particular drugs, in one way, we can say that they are the static agent. Okay, so as with other agents, now let's come back to the point. As with other agents, discontinuation of adafovir, it may result in severe exacerbation of the hepatitis. That means if we discontinue this drug in between, the hepatitis will come back with a vengeance. Okay, it will what to say, relapse. Okay, and the signs and symptoms, they will be grave this time. Okay. So nephrotoxicity, it may occur with the chronic use, and the drug should be used cautiously in patients with existing renal dysfunction. So the adafovir no longer recommended in current hepatitis B guideline due to lower efficacy when compared to the other agents. So next is treatment of hepatitis C. So this hepatitis C virus, it enters hepatocyte following interaction with the cellular entry factors. Okay. So once inside the cell, the viral genome is released from the nucleocapsid and the HCV polyprotein is translated using the internal ribosome entry site. So the polyprotein, which gets formed, it is cleaved by the cellular and viral proteases. Proteases are type of enzymes that break down the protein. So once these proteases act upon the polyprotein, the what we get is that we get structural and non-structural proteins. So non-structural protein abbreviated as NS. So we have core NS3 and NS5A proteins form. These proteins, they form replication complex on lipid droplets, and they serves as scaffold. Scaffold is like a stage or support for the RNA polymerase to replicate the viral genome, which is then packaged in the envelope glycoproteins before non-cytolytic secretion of mature virions. I will again repeat. The core NS3, NS stands for non-structural proteins. The core NS3 and NS5A proteins, what they do, they form a replication complex on lipid droplets. So this is one thing that they do. Second thing that they do is that they serve as a scaffold. Scaffold, as I said, it is a support. They support the RNA polymerase to replicate the viral genome, and this re- replicated viral genome is then packaged into the envelope glycoproteins, and once it is packaged into envelope glycoproteins, it is then released. Okay, so several direct acting antiviral agents, they target the NS3 and NS4A protease and also the NS5B polymerase. The NS5A, it is involved in HCV replication and assembly. They are available. So various targets we have over here, that is NS3 or NS4A protease, then NS5B polymerase and NS5A. Okay, so we have the simiprevir, then paritaprevir, which requires ritonavir boosting, then grazoprevir, then voxilaprevir, and glecaprevir. These are the directly acting antivirals which inhibit the NS3 NS4A serine protease as their primary mechanism of action. So they have lower barrier to resistance than other agents such as sofosbuvir. So use of HCV protease inhibitors, it presents significant potential for the drug-drug interaction. The reason is that they get metabolized by the very common enzyme, that is CYP3A. Okay, so the adverse effect, they include the rash, then pruritus, nausea, fatigue, and anemia. Then we have next category of drugs that are used in treatment of HCV, that is NS5A replication complex inhibitors. So what is this NS5A? It is a viral protein which is essential for HCV RNA replication and assembly. See, these are all non-structural proteins which we have just mentioning over here. They are all required for the replication of HCV. So if they are inhibited, the replication won't happen. So its role in replication, it appears to be formation of a membranous web along with viral protein, that is NS4B, and this web provides platform for the replication. Okay. So if this NS5A is inhibited, there will be no formation of membranous web, and as there is no formation of membranous web, there is no platform available for the replication. Okay. So the currently available NS5A inhibitor include the ledipasvir, then ombitasvir, then elbasvir, then velpatasvir, then pibrentasvir, then daclatasvir. Okay, so these NS5A inhibitors have a number of clinically significant drug interaction due to their metabolism by hepatic CYP450 isoenzymes and also inhibition of P glycoprotein, that is PG.